Welcome, guys, to the Cup of Nurses podcast with your hosts, Matt Slarchik and Peter Findera.
What's up, guys?
Peter, how you doing today? It's a beautiful day.
I'm doing good. It was a cool start to the day. It was in the 50s in the morning here in Chicago, but now it's progressing to the warm 70s. Probably not, probably like 60s.
I know I've been thinking about travel nursing ever since it's getting so cold.
Have you have a set date for this travel nursing stuff?
I do not.
Yeah, but good thing we got the travel nursing checklist for you.
It's going to remain mysterious until I would just put it in 2 weeks.
Yeah.
I don't like gossip and anybody that listens.
Yeah, so Matt's not going anywhere yet.
Yeah.
Maybe next year, maybe next month, maybe next week. I don't know.
Stay tuned.
If you see an empty chair in the next episode, you know why. Matt's gone.
Yeah, Peter's going to talk alone.
I'll use Susie.
Susie from last episode. So, guys, we are a podcast where we tackle hot nursing topics, current health news, and anything related. Thank you guys for listening. Please subscribe on YouTube. Give us that nice 5-star rating if we deserve it on the podcast.
And only 5 stars. And on today's episode, we'll be talking about patient education, a few tips, and 5 strategies for you to implement in your hospital. We're also going to talk about medication called Zantac. That's a common medication that we use, or that people use for heartburn, that you can just get over the counter.
Yeah, it's H2 inhibitor for the receptors. And it's funny because this medication, guys, has been out since 1981. It's been on the market for a while now. And all of a sudden, the Food and Drug Administration decided to say that it's being pulled off the market. This was in September of 2019, that it has carcinogens in it.
Yeah, the actual carcinogen that they're saying that's causing this cancer is a medication or an additive called NDMA. Not to get confused with MDMA. That will lead to different kind of symptoms, not just
Maybe they put MDMA in there. Everybody's going cuckoo.
Maybe that's why everyone's buying it, man, chopping it down, Mm-hmm. But yeah, so this additive NDMA has been shown to cause cancer, and this NDMA was also in another cardiac medication. Losartan. That's why it got pulled off the shelf as well. I wonder what other medications like that consists of, because they're probably getting pulled off the shelf.
There's a few, and it's when I did the research on this chemical is used in like toilet cleaner products. So I don't know if it's used to cut this medication out or make it a longer shelf life. But now because the Food and Drug Administration, they don't do their own research usually. They use research from other sources or from the drug itself, and they look at the results and say, okay, it's safe.
Right. So if you bought your big bulk from Costco, you could use it as a toilet cleaner now. Dissolve it in some water and wash your toilets instead of taking it for your heartburn.
Yeah, and anybody that uses Zantac or don't know what it is, so basically it's an H2 blocker, and what it does, it decreases the acid in the stomach, and it's usually over the counter, and it kind of helps with like acid indigestion or just kind of coating a sour stomach is what they kind of call it.
Yeah, the main people that use medication are people that suffer from something called GERD, and GERD happens. I think it's about 14 to 20% of people have gastric reflux.
What does GERD stand for?
So GERD is gastroesophageal reflux disease, basically.
There we go, for people that don't know.
And what the mechanism behind this is, you have a sphincter in your esophagus. It's called the lower esophageal sphincter. Same way you have a sphincter in your ass. It serves the same purpose. It opens to let things down, and it closes, to keep things from backing up. And some people have this issue where if they eat a lot of spicy foods or certain kind of foods, make their stomach produce more acid, and that acid kind of builds up and it kind of pushes up against the sphincter, and the sphincter opens up because technically they don't have a properly functioning sphincter, or a little bit weaker, or it's been damaged in the past just because the acid does burn a little bit.
So anybody that doesn't know what a sphincter is or still doesn't understand, it's just basically a valve from the esophagus, and whatever you eat, it just closes everything shut in the stomach. And what happens is you eat spicy food, alcohol, you smoke, correct? And if you have
I thought you were going to say you smoke crack, but you said smoke correct.
Okay. Smoke, maintain, if you're overweight, specific foods, what happens is that sphincter doesn't close as properly. And you start having acid leaking, and it starts kind of trailing up the esophagus. So some people that might have symptoms from this is bloating. You might feel like you have something stuck in your throat, but it's really not there. It's just the reflux. Or you might have a little heartburn going down the esophagus. And some people, they use Tums, which is calcium bicarbonate.
Yeah.
And what they do is they decrease the acid. But that's just you putting a Band-Aid, like always, on the symptom. Yeah.
Yeah. So some people take like a handful of Tums just to get it down, because sometimes it's that severe. But like Matt said, a few things that cause GERD, a lot of times it's improper emptying of the stomach or delayed emptying. if you have some other intestinal issues going on where you're overproducing acid or it doesn't get drained properly, that also push the acid up and does cause a GERD.
And some people, maybe they want to take a more natural way of curing their GERD, or if you have it and you don't want to take Zantac, or you're listening and you feel like, oh, I think I have those symptoms and I just never knew what they were. And here are some alternatives to prevent them. One of them is maintaining a healthy weight. So excess amounts of weight on the body kind of pushes pressure on the abdomen, and it also pushes the stomach, which in return pushes the acid up into the esophagus with the sphincter.
Right. Yeah. Another one would be to stop smoking. Like we all have heard this before. Smoking affects everything in your body, and it does cause the sphincter to not work properly. I'm not sure if it has to do with like the blood flow because nicotine constricts your vessels. Correct. I'm not sure if it has a issue with doing that, or maybe because it raises your blood pressure. But when we smoke, we breathe it in, so it's gonna go into all our cells and all our organs. And plus, when a lot of people smoke, they also swallow whatever's left over in that residue, and that probably increases stomach acidity as well.
Yeah, one time when I smoked and I like burped, I just had smoke come out too. So there you have it.
You swallowed a cigarette or something?
No, smelled some smoke. Another one is don't lie down. That could be maybe, let's just say, before a meal, or maybe it could be a nap. You want to probably wait 2 or 3 hours before you lay down or before bed, because having that food sit kind of causes a gateway to having that sphincter being pushed, and you might wake up with like an acidy esophagus or throat and don't know what that is.
Yeah, it's recommended that you don't lay down until 3 hours after a meal. And speaking of meals, then you also want to chew your food properly, just so you chew it and your acid isn't breaking down whole chunks of meat instead of smaller ones. Like if you make a burger on a pan compared to if you chop out the burger and make like sausage crumbles or whatever, it cooks quicker that way if you think about it, because the oil goes around it more. Same with your gas. There's more surface tension to go around.
And plus, like, digestion starts in the mouth. It starts with saliva, and saliva is actually a buffer that helps coat everything to help with the first process of digestion and turning it into chyme is what they call it, right?
Yeah, I think it's chyme. Chyme.
Good old like nursing 101 revisitation there.
There you go.
Or anatomy even. So you want to chew your food, and it's even called like mindful eating, where don't look at your cell phone, don't look at your food. Like take that 15-20 minutes and actually look at what you're eating and feel it and put it in your mouth and enjoy it in a way. Not just mindlessly eating, because you know how nurses even eat too. You're eating in front of the nurse's station. Don't watch TV. Just actually create a good, healthy relationship with your food.
Yeah, people always tell me that I should slow down with my eating because I don't enjoy my food. Just because I eat it so fast, but I do enjoy it. It tastes good. I want to eat a lot of it. Put it all in my mouth, like that.
I guess.
Another one is relaxation therapy. So, like meditation, a lot of stress, like you mentioned multiple times before, it affects your GI tract, and, esophagus is part of your GI tract. So a lot of times if you feel a lot of stress, your stomach kind of constricts a little bit, or you just overproduce acid in general just because of all the hormones you're releasing.
That covers it there.
Yeah.
We are GERD free. And if you have it, another one, we kind of touched about it, but make sure you're avoiding all the foods that are triggering your GERD. That's alcohol, foods that are very processed, deep fried foods, alcohol, of course, and
smoking.
Caffeine is on there as well.
That caffeine, I'm sure caffeine, yeah. Because I know when I take caffeine, it like makes me poop more frequently, more loose. It gets things churning. But so next thing, so a lot of stuff that goes on in a hospital, a lot of discharges and admissions going on. A lot of times people neglect patient teaching, or even when we chart, we kind of just bypass it. We just zombie-like just chart. Yeah, we taught the patient about central lines. We taught them about sepsis or the plan of care. A lot of people neglect actually going into the room and actually teaching the patient about this stuff. So we're going to offer you guys a few tips and strategies for you to better educate your patient, just to prevent readmissions. Readmissions are a really big issue going on, and it's very costly for the hospitals.
It is, and we as nurses, I feel like we're the jack of all trades in healthcare. I feel like back in the day, it was a physician's role to provide education, and they still do with procedures and things like that. But afterwards, nurses are the core being of the hospital to provide education when it comes to discharge, bedside education every single night that they're there. And I feel like that little section in and the charting system always gets neglected. And I'll say it myself too. Sometimes you just like half-ass that charting because you have no time, you're running behind. But the question is sure, you're half-assing your charting, but how are you educating your patient bedside? And that's what's crucial.
Yeah, and we clearly see that one of the main causes of readmissions is poor teaching, especially for like OR patients that come in for like hip replacements or things like that are more. It's like a drastic surgery, but they're pretty much healthy for the most part, except they need like a new hip or like a new shoulder or something going on in the bone aspect where now they might need to be on anticoagulation or they might be on medication now, or they come in the hospital, they haven't been there for a while, now they get diagnosed with a bunch of things, hypertension, now they get thrown a bunch of pills upon discharge. And that's when a lot of times teaching falls off and patient gets readmitted because they're not sure what the signs and symptoms of their medication is to warrant coming into the hospital or getting in contact with your physician.
And a very basic one could be like heart failure, right? There's so many patients that are diagnosed with it and they get sent home with different medication like Lasix and antihypertensives, things to help with their contractility. And they're told to avoid sodium, right? To monitor it and then also monitor your weight. If you gain more than, is it 2.2 kilos?
1 pound.
1 pound in a single 24-hour, you're supposed to let somebody know, like your primary doctor, because what happens is this patient doesn't weigh themselves. They wait 2, 3, 4, 5 days, whatever the case might be. Their feet start swelling. They neglect that as well. They go into fluid overload. And most of those patients, they come in within a 30-day time frame for something that's very, very simple, something that could have been prevented, like taking an extra dose of Lasix, which is an anti-diuretic, and that would help you get rid of the fluid. But no, they wait till they feel like they're freaking drowning in their own body and they get called an ambulance at the hospital.
Yeah, so Lasix is actually a diuretic, not an anti-diuretic.
Correction,
So
diuretic.
Diuretic, yeah. So yeah, a lot of times like they can just give an extra dose of Lasix, and a lot of times we say try and eat a low sodium diet, and we tell them to avoid salt. So a lot of times what patients do is they stop putting salt in their foods, but they still eat the same salty foods from cans or from whatever, because these people come from different social economic backgrounds, and when you say avoid salt, to them that means to not put any more salt on my eggs or certain things, but they're still eating these high salt foods, which has to get touched upon as well. But that just depends on your patient population.
And we as a healthcare profession, anybody that's in nursing school, becoming a nurse, thinking about it, or are a nurse, we have to understand that more than 50% of Americans in the healthcare field are illiterate. They don't understand the basic little things that we do. They don't understand how to read nutrition labels and how sodium is in all these canned foods. They think, just like you said, it's just sprinkling the salt, and it's really not. So we have to really dumb it down, guys, and give people the proper tools, the proper mindset to educate them to prevent healthcare readmissions, which in return is going to help our country and maybe get you another raise at the end of the year.
Yeah, I've actually had a patient that didn't know how to read, but he didn't tell me and nobody disclosed information to me. So I had him for probably had him for 2 nights. Well, I had him for 3 nights, but I found out on the second night. I gave him like a pamphlet to read, and he's like, "Okay, thank you." He didn't tell me he wasn't illiterate. And then nurse that I gave reports to is like, "You give him reading education?" I'm like, "Yeah." He's like, "He doesn't know how to read." I'm like, "No, I did not know that. He didn't tell me anything, and it wasn't anywhere in the chart." And like, "Oh yeah, we'll put it in." But sometimes it's kind of embarrassing for the patient to say, "Hey, I can't read," so they're kind of just be like, "Yeah," or they're nod their head just for you, just so they don't feel embarrassed, or they are embarrassed that they know how to read, but they don't want you to think less of them that they don't know how to read.
Or
so it's more common than you might think.
That, and like imagine how stressed out they are with what's going on, or they have a new diagnosis, they have a new procedure, they're nervous, they have anxiety, they fear, and here you are trying to teach them in that kind of state. Like their mind is not set to teach. They're not ready to learn. They're not ready to take information. You have to somehow cross that barrier with them and assess with them whether the education that they're getting is proper.
Exactly. And with the whole, unable to read thing, like a lot of our education that we give, a lot of stuff that we do in the hospital, it's all literate. It's all based on literature. Like we come in a room, we write on our whiteboard. You got to write your name, your phone number, and they can't read that. And even when you put the TV on, sometimes you have like the therapeutic communication channel going on where, they're writing stuff or they're doing something and, he doesn't know what that means. It's very, very scary. Like you have signs all over the place, and he's been illiterate, so he can't read any kind of sign. It's so scary. And now, like Matt said, you throw them in a hospital where they lack control of what's going on, and they're sick, and they're having undergoing a bunch of these changes. That's super stressful. It's very sad as well. And now you can't provide this good teaching because he's scared to tell you that he doesn't know how to read.
Yeah, and eventually, the longer you're a nurse, you're able to have the holistic approach to medicine. Like you're able to take that one patient and you're able to find out like what's going on. And let's use an example of a patient that has pneumonia. Let's just say they came in for sepsis pneumonia. Like the patient comes in, they roll in, and they have family, they have no idea what's going on. And me having my experience, I know already like the plan of care, right? And I usually like to educate the patient of everything that's going to happen tonight, just so they have a general idea of how the night's going to go by. And you should do that. So listen, you came up for the ER. We're going to give you antibiotics for the reason why. We're going to repeat the x-ray, why, and explain everything of what's going on. Or if they have pressors, where I explain why they got a central line placed, why do they need it, and I explain everything to the family that's going to happen for that shift. And they have sometimes closure or a peace of mind, not that things are up in the air. Oh, something might happen in the hospital.
Yeah, that's actually really good approach. And I think every nurse should take that approach where you should explain everything you do to everybody in the room, just so everyone's on the same page. And you won't ever over-explain anything, just because this is such a new thing to them. And it's a constant learning process for the patient and family.
And when it comes to being a new nurse, sometimes you're so focused on the tasks and everything that has to be done, or you're looking at orders, that you're not able to kind of grasp the idea of everything that's happening. And it took me a while, man. I think a good 2.5 years, 2 years is where I was able to really put the puzzle pieces together and understand the care of every single patient, how their kind of night's going to go by.
Right, yeah, especially since, yeah, like you said, and when you're a novice nurse, you don't know everything yourself yet at all either. So it's kind of, sometimes it's hard for you to explain something because you yourself don't fully understand what's going on. You just know that you have to do this, this, and this, but you don't know why. So it just takes a little bit of time of being proficient, actually doing the task. Then you can finally understand why you're doing these tasks, and then you can explain to another individual. But back on readmission, so 14% of patients in the United States get readmitted. That might seem like a small number, but that entails millions and millions of dollars. And the HRRP basically has these standards, the core measure standards, where they focus on these seven main things where they really look at the readmission. So it's chronic lung disease, coronary artery bypass surgery, heart attacks, heart failures, hip and ear replacements, and then pneumonia. So that's 7. Did I say 6? But yeah, so these are the ones that, like the main ones that they look at for readmissions. But these 7 are basically everything that people come in for.
Yeah, and not only, but these core measures are backed up by science and research, and they have the evidence base behind how things should play out, and every hospital is held accountable to it. Just like you have a patient has a stroke, their core measure is to get that patient into a CT scan within, 35 to 30 minutes.
I think 30 minutes, yeah.
30 to 45 minutes, something. And within, I don't know, is it 3 hours? I have to look up the core measure.
So, yeah, so that one is, I believe it's like 30 minutes to an hour with the CT, probably 30 minutes, I want to say. And then to decide if it's ischemic or hemorrhagic. And then you have 3 hours from their last normal to give TPA as a standard. I know some hospitals do like 4 hours or 5 hours or 6, but but the standard is 3. Then you could obviously change it up a little bit, just because for strokes it's a targeted therapy where these are the 2 things that we got to do. It's either we're going to revascularize the area if we can, or we're going to need a TPA it.
Yeah, and that's a core measure that every hospital should follow. The CMS, which is it's a government body that holds hospitals accountable to that. And now they're adding, for example, sepsis to that, meaning if you have if you have a patient that has a lactic, you have to give fluids, you have to give antibiotics, you have to repeat the 3 serial lactics, you have to do blood cultures, and I think there's something else. And if there's 2 blood pressures with less than 90 or a MAP under 60, you have to start pressors. And that's a core measure that supposedly in 2020 they're going to really push for.
Right, yeah. So these 7 issues are so common with these readmissions where they're actually standardizing this treatment, because they have to make sure that everyone's getting good treatment, because otherwise if you get these things done, you're more likely to come back in 30 days if these things aren't done efficiently. If you're not properly treated for a cabbage or a heart attack or heart failure, you're going to come back in 30 days, because those are like serious life-threatening injuries. It's not like, diabetes where it forms over time. These are acute issues that happen. And if you're not properly treated, you're going to come back to the hospital or you're going to end up dying.
Yeah. And just for clarification, just to find out how severe this is, in 2011, hospital readmission cost annually for all of the United States was $41.3 billion of
Change.
unwanted costs from readmissions. And when we look at in 2018, the Medicare cost, it was 26 billion annually. And they're saying that $17 billion a year of that spending could have been avoided for hospitals after discharge, according to the data from the Center for Health Information and
Yeah.
Analysis.
So imagine that money being put somewhere else into like prevention or, you know, building walls for Africa or something like that, that's more for our health. Like prevention clinics, people are suffering, and one of the things we lack the most here in the United States is prevention. Mental health is also a big issue. You see mental health facilities and clinics closed down all the time. Imagine 17 billion being put towards something like that to better our well-being and everyone else's well-being.
Yeah, and I don't think we sometimes understand the. It's also, you say I only one person does it, but if people continue doing it, and people push for it, there's going to be a change that happens.
Yeah.
And what Medicare started doing too is they started holding hospitals accountable. I think in 2019 is after the Affordable Care Act started, every single hospital is gonna start getting paid penalties, and I think it's up to 3% of reimbursements that the Medicare withholds from the hospitals because of these weird admissions.
Yeah, and that's kind of both patient and hospital's fault. You could say it is. I guess it depends on where you are and how good your hospital is and your patient population. But yeah, I see it being fair that they penalize people. So they penalize up to 3%. So if your readmission rate is 1%, you get 1% penalty. It goes to 3%. Unfortunately, if it's 10%, then obviously you're gonna get fined the 3%. But that's still, if your readmission rate is 10%, that's a big chunk. And I'm sure some hospitals have even higher, because if the average rate is 14%, then there's for sure some hospitals that have like 20, 15%. And some hospitals have like maybe 1% or 2%. But so readmissions are a big issue. That's within 30 days, right?
It just starts pissing me off where the hospital is having this issue. We have meetings about it, but what they start doing is they start cutting costs to facilitate this kind of whatever problem. And what they do is they start cutting us. They start cutting our little things that we enjoy, like getting gift cards for our birthdays to go downstairs to the cafe, like little things like that. And it could be maybe raises they start kind of threatening. Or what they start doing is, I've noticed, they start getting shittier equipment. The Foley catheter kits are not as good, or they're getting shittier IV start kits. And then if you wonder, well, you're paying less for a Foley catheter kit, but now UTIs are going up, and now we have more urinary tract infections. Their solution is, oh my God, we got to take out the Foleys earlier. Why does that patient have a Foley? And now this is a big thing of the Foley has to be removed. We straight cath. That creates more room for infection. So instead of solving the real issue,
Right. Or they say, we gotta do in-services and we gotta provide more nursing teaching. But you can teach me how to put in a Foley, but if the piece that you insert the Foley with isn't sturdy enough, or it's poor quality rubber, then obviously it's gonna take me a few tries to get it in. And then that's kind of not fair. Like, we recently got new A-line tubing and Swan tubing. I don't mind them. They probably switched because it's probably cheaper, but we'll see how that plays out. Same. They do the same thing, but it's just kind of a little bit different. Like, instead of like a clip to squeeze the water through the pressure bag, it's now like a little nipple that you pull.
Interesting. It's kind of goofy for a lot of things. Even like we had, they do skin meetings once a month or twice a week, twice a month, usually when a group of nurses checks everybody's skin and they see if it's charted properly. Well, supposedly we weren't checking the patient's, 4-eye skin assessment, and their way of intervention was to have a binder where the person that goes on the shift and leaving, we have to sign off for each patient, and they put a giant poster on the door before we leave. Don't forget to sign your binder. Well, it's not even a legal document, and we all said, like, what the heck is this? So we started resisting it technically, and people weren't signing it. 1 month later, no one talks about the binder, and it's just funny. They always find a way to punish us instead of ways to make our job easier sometimes, or hear us why we should do A, B, and C.
Yeah, a lot of times their idea of making a solution is to, hey, let's
punish the nurse.
Let's add a little more extra shit to the nurses and let's punish them, and then hopefully they'll change or it'll change, which doesn't work. Like, we have measurement Monday for our wounds. That's usually when the wound care team comes around and checks all the wounds, but we still got to measure them every Monday. And they also do like cap change every Tuesday and Saturday as well. So we have like those things, but those are little things where you can just chart in like the charting system. You don't got to write your name anywhere or sign anything. But we'll see what happens with in 2020 or 2021. See if these readmissions keep going up. We're gonna need to keep changing things. And usually nurses get the short end of the stick out of all this.
And if you keep listening to the podcast, you'll be up to date on this. So that's why we're here for the long-term game, right?
Yes, we are.
Going back to readmissions, so there's a little bit of a statistic that shows patients who report not being involved in their care decisions report that they have a 34% higher odd chance of readmission.
Yeah, so I actually looked at the study. The study took people from April 2011 to March 2014, and actually took in a little over 24,000 patients. And mean age was 52. This was post-op patients. Excuse me. This study showed that patients that got a little bit of patient teaching, like pre-discharge, 18.6 of those patients were readmitted. And they kind of looked at other stats depending on how much teaching they got. So a patient who reported not being involved in their care decisions, their readmission rate was 34%.
Wow.
And then a patient who reported that they did not receive any kind of written information during hospital stay, their readmission rate was 24%. And then patients that were not properly educated verbally, then were not provided with any kind of written materials, and were not as engaged in their care, 54% readmission rate was for that. So those patients, they were taken care of properly, but they weren't educated. They weren't taught verbally or via like written, and they also weren't asked questions about their patient care. So they were provided patient care, but it wasn't patient centered. It was just like general. Half of those patients were readmitted.
And I'm not going to lie, I think education is a huge important strategy to help readmissions. I think that every nurse should be providing great patient education because it makes a difference. Plus, it's preventive medicine, right, to try other aspects of eating healthy, whatever you teach them. But also the double whammy sort is the hospitals keep putting more things for us to do. Yeah. And the question is when is enough? So we know that we should be doing it, but we neglect it because it's something that could get pushed away and no one knows. And we keep getting slammed with more things, so we push away one of the most important things to help with readmissions. And I don't think a hospital sees that.
It's very true.
For them, it's just cutting costs, which is making the grid worse for us, meaning it takes more nurses to get patient ratios, or we don't get a tech on nights because you don't have 12 patients. So they use all these little things to save costs, but they're not realizing the bigger cost, which is hospital readmissions, let's just say.
Exactly. If they get fined at 3%, that 3% is usually going to go on to nurses, because they're not going to pay the physician any less, because the physician is going to end up leaving, going to a different hospital. Hospitals want to keep their physicians because they've been doing the same procedures and having the same patients over and over again, because these physicians bring in the patients. We're the ones that take care of them.
Yeah, and not only that, is the people that run the hospitals, they're usually not nurses. They don't have hospital backgrounds. They have healthcare administration. They weren't bedside nursing, and they don't know what it is and how it feels like and what's actually really going on. Yeah. For them, it's just number munching. Oh, this is the fiscal year. Okay, we got to cut costs, and that's it.
Right, it's a business. That's to make this quarter better than the next one. But I mean, I personally like patient teaching, because while working in hospital, we see a lot of acute care going on. So we're usually the ones they're treating. We don't do much prevention. I feel like this is my opportunity to provide prevention to the patient, to make sure that they know what they're going home with, and to make sure that they don't get readmitted for the same issue. And I actually like that aspect. And I like, I like telling the family members too what's going on. I feel like, we're very informative on the unit that we work at. So we're very informed on the diseases that we deal with and the processes and the plan of care. So why don't we just share that with the most important person, being the patient.
And you got to have that attitude and mindset. I feel like some nurses aren't meant to be nurses, and they don't care for that. They just go there, work the job, pass the meds, do whatever they have to do to keep the job, and that's it. Yeah. But let's go over the 5 strategies for providing high effective patient care and education for them. And the first one is discharge planning starts at admission. And why is that important?
It's super important because, like we said, we're in acute care. So a lot of these patients come in feeling fine, and then all of a sudden they feel like crap. You want to tell them why they're admitted in the first place. So, hey, this is what's going on. Your sugars 500, you're in DKA. We're gonna need to try and get your sugar down. We're gonna put this IV in. We need this IV because we gotta put you on an insulin drip. We're also gonna give you D5 on the other IV because we don't want your sugars to drop too low too quick. And we're gonna check your blood sugar every hour. Why we're checking it every hour, I know it sucks, but you're on an insulin drip, so we gotta change up the insulin rate every time you measure your sugar. That's why we need all this data together, just so we can provide you with the best patient care. And this is the standard practice that we do every time a patient with your condition comes in.
And we have to follow up also with what's going on. And I know it's neglected as well. For example, we should take advantage of technology, right? So we could provide them printouts of any kind of pill. Let's just say they have a new pill they're starting, or they're on, let's just say, heparin in the hospital. They don't know what it is. They just know they're just getting poked with a needle. Like my dad, he didn't know what he was getting. He's like, yeah, I'm just getting poked with a needle.
It thins my blood.
It thins my blood, yeah.
Actually, decreases platelets, but whatever.
Use technology as a tool. Like go on your MAR, click on reference manual, and print out the little script of a couple pages for what this medication is. Give it to them. Explain it to them. Let it read it themselves. I know language is a barrier too, but if they speak English, that's fine. You could provide that for them.
And the best way to do this is when you're scanning your medication, be like, hey, this is your metoprolol. This is your heparin. And then at the end of the list of medication, just ask, hey, are you familiar with any of these medication? And they're usually like, yeah, that's why I usually take for my blood pressure and the Coumadin's for my blood. It thins my blood. It makes me not get clots. And you're like, okay. So that kind of, now they know what metoprolol is. You know that they know because they've been taking it. You know what Coumadin is because they've been taking it as well. But maybe Protonix is something new. Like, yeah, I haven't taken any Protonix. Like, oh, you haven't taken any Protonix? And they're like, no. So I'm like, okay, well, let me teach you about Protonix. It does this, this, and this. So that kind of, just you reading the medications and just saying, hey, are you familiar with any of these? And they'll tell you yes or no. Sometimes you get those patients that are like yeah, I know all these, even though they don't, but that's just like their fault. You can't do much. Or what you could do is sometimes test them. If you have one of those patients that just says yeah to everything, you're just like, yeah, this is metoprolol. Do you know what you take it? Do you know what you take it for? And they say yeah, and you're like, what do you take it for? And they're like, I don't know. You're like, I got you, huh? So you don't know what you're taking, and then you kind of provide teaching, and then not be stubborn and just give you attitude for it, but still at least you taught them about it, and they're for sure not going to forget anymore.
And that's a good way to do it because you're already there anyways. You're already doing the task of passing meds. Might as well make it more interactive and fun for the patient. And I know sometimes on the WOWs, the work on wheel stations that we have, they have like a little sticker that says, ask me about the medication you're getting. So they use little titles, like little posters they put on the back of the computers to have the patient ask us. But as a hospital, we shouldn't be telling the patient to ask those questions. We should be doing it for them because we should understand what they're going through,
Yeah, but yeah, sometimes people are embarrassed because technically we're nurses are like that a little bit. Some patients look at us as like we're more superior, more educated, more about that. So that little flashcard on a computer might show that, hey, it's okay to ask that question.
Yeah.
People ask that question instead of like, am I the only one that's gonna be asked that? I don't want to feel dumb, to ask that question. But if the fact that they have that little note card saying ask me a question, they're more prone to ask.
Yeah, and even another one, using technology, right? Go on Google, guys. I always do this. If there's a family, and I had a patient that, for example, was vomiting some blood, came in, he had an EDG done, and he got his varices banded. So in the esophagus, there's a lot of vessels, and what happens if you have portal hypertension, meaning backup of blood kind of from the liver, your vessels could pop. If you're a drinker, usually this is for long-term drinkers. So the doctor went in there and he put a little band, basically a rubber band around the vein to stop it from bleeding. But they didn't know what the procedure was. So I went on Google, I typed in esophageal varices, I typed in the word banding, I found an image, and I explained it to the patient and for the family members. And that's sometimes how I use technology too, because most people are visual learners and they're able to visualize the esophagus, or they're able to visualize where the stent is in the heart. And for me, I feel very happy when they understand that. Right. And I love doing patient education like that.
Yeah, same. There's a handful of patients that ask me when they come up with swans. They can't see their swan because of their neck. You can't see your neck. So a lot of times they ask me to take a picture of it. And that gives me an opportunity to tell them how the swan works. Like, hey, this yellow cord that's going into your neck goes all the way to your pulmonary artery. And when I do your numbers, there's this blue part that actually goes into your right atrium. That's where I shoot my numbers. And then the fluid travels and it gets like a temperature and it's like a time gauge to see how efficiently your heart pumps blood and how And then I do my mixed venous, which is drawn off the PA. Remember, that's the one that's in your pulmonary artery. And that shows how well you're using oxygen. So that gives me a good approach because that shows me they want to learn. Because the fact that they want to see how their swollen looks like in their neck, that just shows that they're willing to learn. And that's when I go ham.
Yeah, and the second one after technology, you have to identify the patient's learning style. Everybody learns differently. Not everybody's the same, and you have to learn to assess that. And sometimes you'll assess that, and you can tell that the patient doesn't want to learn at all. They're very stubborn. They don't give a shit, unfortunately. And those are the people that I'll still explain it to them because it's my job. But I don't feel guilty if they don't do anything with it because I can't force somebody to learn.
Right, yeah. I can't teach you if you don't want to be taught. That's kind of thing. But you have your visual learners, and your audio learners. So you want to differentiate. Do they just want 2 pages worth, just 2 pages of words listing facts, or do they prefer pictures with a little bit of writing? Or do they prefer no writing at all, or they just want to have a conversation with you where they could ask you certain questions and they could kind of follow step by step. So just assess your patient, see what learning style is the best.
Me personally, I feel like it's most effective. It's just like that. I said that visual way of showing them actually with like what's going on and explaining the disease process.
Yeah, I like the visual with text because, like I said, you're not 100% sure what they like, so you can do 2 at once. Next one is you want to consider their limitations and their strengths. So if they have hearing aids, you probably need to talk a little louder, and they mostly are going to prefer something more visual because they might mishear the words you're saying. And same with someone that wears glasses, especially if they have like bifocals and are like 4 inches thick, where they got you're like you have a piece of paper and they're struggling to look at it. They're like holding it 2 feet in front of them, then going back and forth. Those are probably more beneficial from like audio, just because of the fact that they probably do more audio at home than visual if they can't see properly. And make sure if they're blind, you don't want to hand them a pamphlet because it's not going to work.
You said what?
If they're blind, you're not going to hand them a pamphlet.
I'm so sorry. I thought you said if they're blonde, don't hand them a pamphlet. I'm like, who are you going after right now, man?
Myself.
Yourself.
And if they're blind, obviously you don't want to write. And if they're deaf, you don't want to, play a podcast in the background.
Yeah.
You want to give them YouTube.
I actually told my patient before to check out the podcast on a specific, I think it was the episode about vaccines. I told him to listen to it. Except it was kind of, quick story, guys. It was kind of awkward because the patient's wife came back, and in that podcast episode about vaccines, don't know what number it is, Peter mentions how the vaccine, what is it called? The hoax?
The host?
Or the fake news kind of, it started from a porn star. And she knew who it was, and she's like, I don't know if she's a porn star. I'm just like, you know what, to be honest, I'm not too sure. My friend looked up the research, not me. I'm like, I don't know what to say. But it's just funny how she came back at 5 a.m. and we're talking about basically the anti-vaxxers and the porn star. She's like, well, she does look pretty good. I'm like, oh my God, man, I can't believe I'm having this conversation.
Yeah, that's funny, dude. That's good. They're listening. So, that kind of shows that they're doing it. Listen to the podcast and actually learn about this kind of stuff. That's
one of my patient education tools. Check out the podcast.
There you go.
Anyways, the next one is you want to stimulate the patient's interests. Just like Peter said, you want to maybe see and ask them and question them about a specific pill. You want to ask them about the disease process, or you want to ask like little open-ended questions. So it gives them the ability to kind of talk, and you could assess like what they actually know. If it's like heart failure, you could ask them like, do you know why you're in the hospital? Do you know why you were readmitted for heart failure? If it's a stroke, you want to ask them the 2 different types, or why they got TPA. If they got stented, why don't you ask them, do you know why you have the stents, or do you know why you have to be on Plavix, which is an anti-platelet regulator, whatever, for that reason. So you always want to like really test the patient's interest and stimulate that room for learning.
Right. If you're trying to educate your patient and he's just not being like responsive or not giving any kind of feedback and just being a dick, what I always do, because I work with LVADs, I always say, hey, if you don't take your Coumadin, your pump's going to cut off and you're going to die. If you bring in the word death into it, if you don't do this, this, and this, you're going to die. A lot of times that they perk up a little bit. They're like, shit, I didn't do that and end up in a hospital. And you end up in a hospital because you're not following our instructions last time. So next time you might not get so lucky. You might just full out die.
And there's also those patients that are usually like, let's just say the alcoholics, man. The ETOH patients, you can tell them drinking is bad for you. This is literally going to kill you. You're literally going to be coming into the hospital and getting your stomach tapped to get rid of fluid. And you'll tell them all this scary stuff, but like they're connections are so strong and they're so addicted, and they haven't followed neuroplasticity, right, to break the habit of being themselves. They continue drinking and they continue coming for ETOH withdrawals, and it sucks seeing them. And those are the people that I usually tell them what I have to, and they do whatever they want with that because they're so stubborn.
Right. Or like your drug use patients that they overdose and they get brought to the hospital and it's happened 4 or 5 times. And like they're the frequent flyers where every time they overdose, they feel fine because they get saved. They keep getting lucky and lucky and lucky, and eventually that luck runs out. But they're gonna keep pushing themselves to the limit just to get that fix. Why? Because the drugs and alcohol are just so strong and so mentally encapsulated in them where they are gonna do no matter what. And now they have this kind of like a feeling for like a second life that, hey, it's okay. I mean, they're not thinking in their head that it's okay to have an overdose, but they're saying, if I overdose, I do have this backup of getting saved. I've been saved 4 times in a row. I'll probably get saved again. But it's not always happens, and that's when people overdose and they die. They get too cocky. They just keep doing these drugs and they keep drinking, and eventually, they don't get, they go to cardiac arrest, or the ambulance doesn't get there on time, and now they're intubated, and we just called them for 2 minutes. We brought them back, but the brain damage is so severe that they're not gonna be themselves.
They're anoxic. And I had another guy too. Sometimes I'm like, I question how much I could talk on the podcast when it comes to like HIPAA and stuff. But I had this patient that she was 24. Dude just came in multiple times for drug overdoses, and his favorite was like some kind of synthetic Xanax. Dude was literally, before I came back, I saw him like a month ago. He was on BiPAP, signed himself AMA. The other time I saw him, the guy has fucking swearing here. Sorry, guys. Tis, indeed. He has purple hair, like a mohawk. Guy comes in for, again, Xanax synthetic overdose. This time he's intubated. The family already knows the drill. He lives with his parents. They already go home. We extubate him in the morning. Guy signs himself out AMA again. Like sometimes that really bothers you, a nurse, because you can't really get through those people. And that's when you feel like hopeless as an advocate for the patient or as an educator.
Right, yeah, you literally burn yourself out. It's like this guy keeps going back and forth. You see him here it is. For the same exact thing every time, and I got provided the same damn education each time. And he's actually gonna listen to it, and I gotta, especially if he's like, rowdy or he throws some bullshit at you, just like, I gotta deal with his ass now. And nobody wants to deal with him, but now I have to deal with him. And people hate the guy. I mean, not that they don't hate him, but they just hate taking care of him because he's just a pain in the ass.
Yeah.
And then he just signs himself out AMA. You're just like, well, that was 12 hours worth for shit.
Because sometimes you get that little dopamine rush of like a reward of happiness of a patient that understands what's happening and you did a good job.
Right. Or you want to be that nurse that's like, I'm going to go the extra mile and, I'll provide extra patient care for him. I'll try to focus more on him. Maybe, he'll change. And, and he's all happy he walks out all happy. Like, yeah, he thanks you. He's like, thank you so much for you doing all this for me and taking your time to talk with me. And then next month, bang, same shit.
Yep.
You're just like, dude, what the hell, man? Like, I did all this for you, and you're still here for like the same stuff.
And then you have the nurses that take things very personally, to heart, and they sometimes take their emotions home from the hospital, and they get burnt out like that because they care so much, and some nurses you hear, they think about the patients when they go home, and this happens, and I do it too. But like, you have to unplug, guys, because it's a stressful job that we do. I mean, we're literally dealing with death and dying and all the other aspects, and what is it called? Physicians. I have a little story too about a physician if you want to hear it, like a nurse practitioner. I don't know if we have time for this one.
I'll take a listen. I'm all ears, Matthew, all ears.
All right, guys. Well, we have one more tip to cover, including family members.
Well, does the story relate to the prior tip, or
no? It's just me not taking shit from a nurse practitioner that decided to be smart and call with me with attitude. So I kind of like filed the policy, and I filed a little risk master on her.
There you go, bit risk masters up. File them risk masters, dude.
But it's, long story short, it was just like one where if you're in the intensive care unit, a physician should talk to another physician for the consult. And sometimes we just call the consultant because we don't have time, but the physician should still do that. And I was fighting for a consult to get a nephrologist onto this patient because of low urine output for like 6 hours. I asked the intensivist, they're like, ask their primary. Well, I asked the primary, and they're internal doctors, so the internal doctors have an AP, a nurse practitioner on, basically, or what's the other one, nurse practitioner or
PA.
A PA. And I asked her for one, and like an hour and a half later, she puts in a consult for a nephrologist, like 10 minutes before change of shift. I'm like, you mother smarty, huh? Because then she leaves and I leave, and so I perfect serve her back. I message her back, hey, it's physician to physician. She calls me with a freaking fit. There's attitude of, I've been working here for 2 years and I have never heard this issue. I've never heard calling physician to physician. I'm like, really? And me and her kind of were bumping heads because I don't want to take shit from her. I'm like, well, nurses are usually pushovers. I'm not going to do that. Well, she's like, if you call, you call, but I'll just tell the day team. So I messaged my manager right now. I'm like, listen, dude, I'm not going to take this verbal abuse. Like, how do they not know this if it's in policy? And I filed the risk master.
Yeah, there you go. A lot of nurses, they take a lot of lip from doctors, and they just take it. They don't file risk master or anything. But physician on nurse bullying, that does occur.
Yep.
And you have full right to report this. And you do more harm of not reporting it. Just because if this physician did this to you, more likely this physician did it to somebody else. And it's going to keep happening until this gets addressed. Maybe we could do not nursing, but a podcast episode about this. Like lateral bullying or even like physician to nurse bullying.
Let's do that when we get the guests on.
Yeah. So we'll move on to our fifth tip. Well, thank you, Matt, for the story. Matt takes shit from nobody except from his patients.
I don't care if you're a physician or whoever. I don't care if you have a master's or a PhD. We're even. I see you eye to eye. Come at me.
There you go, business. All right, so the fifth one is to include family. So this is could be a little bit iffy, just because some patients, even though they come in with family or they come in with people with them to the hospital, they don't want them fully included or know exactly what's going on. So that's why when I get admission or like a transfer, I always tell the family, hey, can you wait in the waiting room? We're just gonna get your patient or get your significant other or your family member ready. We're just gotta wash up the chlorhexidine, change your gown and all that, give a little privacy, and they're okay. And that's the time that I take to ask the patient, hey, who's that's here with you? And they say, oh, this, and this. And I'm always like, would you want them included into like my teaching or patient care? And they usually say, yeah, but there has been a few times where it's like, they tell me that they don't want them included in this. They don't want to know any information. They want the information to go from the patient to themselves, not from me to the family member, which is completely okay. But the fact that you isolate the patient, that allows you time to just be one-on-one with the patient and see what they actually want to tell their family member, because there is people that get abused, and when that family member is in the room, they obviously get scared and they don't want to say anything wrong because they know that when they go home, that family member is going to abuse them or it's going to lead to negative consequences. So that gives you that one-on-one patient communication, patient contact where no one's there besides you and the patient, and it's a free room to talk.
Yeah.
So it's good to do.
I just had so many stories I want to share, but there's just no time.
Yeah, plus the camera died.
One of the cameras died, guys. But it's so important to do that. And you're right. I think when the patient gets admitted, you ask all those questions. And sometimes when you educate not only the patient but the family member, sometimes they're a little bit more healthcare literate, or they know how the patient is, so they're going to hold them accountable when they go home after discharge.
Exactly. Or a lot of times when we get this elderly population, their kids or the family members are the ones actually taking care of the patient. They're the ones that are doing the dressing changes. Even though you still have to provide education to the patient, you got to educate the family too, because if they're the ones going to be doing the stuff, or if they're the ones that are going to be checking the patient's blood pressure and giving them metoprolol, you want to make sure they know the parameters and know exactly what's going on, because they're the main caregivers.
Yeah. Or like for example, my aunt, she had the open heart surgery, but my uncle takes care of all the pills and knows what have to be given, and he's the one that's on top of her. Hey, did you take your pills today? Hey, did you take your Coumadin and all that? So yes, guys, not only is the patient involved in the education, it should be the family, because it's holistic, and that family member is going to probably hold that patient accountable when they go home, because we don't know what the family dynamics are when the patient leaves.
Yep, exactly. All right. Well, thank you guys for joining. Talked about what GERD, Zantac. If you have Zantac, it's actually the recommendation. FDA recommendation is to, if you take Zantac and you prescribe Zantac, you should keep taking it. But for ones that don't need Zantac, you should stay away from it and try to use a different over-the-counter medication for Zantac.
Or if you use it, try out those little tips that we had to prevent GERD before you just taking the pill. Like, change your lifestyle habits first.
Yeah. Maybe if food's triggering it, it's a lot easier to stop eating a food than take a pill for it.
Exactly. And patient education, we covered the 5 tips, why it's important. Hospitals pay a lot of money for readmissions, guys. It could be affecting your damn raises.
Billions
of dollars. if not trillions, as Trump would say. So, guys, make sure we are really educating patients properly. And if we're not, find the barrier to it, tell your freaking unit, and solve that barrier, guys.
Yep. Have a good one, guys.
We'll see you guys next week. Take care.